Hi guys, this is Dan for GeekyMedics.com, and today we're going to be talking about CT head interpretation. So I know for some of you guys this will be your first introduction to CT heads, whereas for others it will just be a refresher session. In either case, we're just going to go through CT heads from the very beginning, starting with the underlying principles and finishing up with a nice way to interpret the images, whether it be in an exam or on the wards. So CT head scans are a very common imaging modality. They're requested very often in A&E for patients who come in with altered neurology or a history of trauma. And they're always requested on the ward as part of a falls assessment if the patient has altered neurology following a fall. So just a bit about the structure of this session. We're going to go through the underlying principles first, then a thorough interpretation method, and intertwined into that we're going to look at some common pathologies along the way. So how do CT scans work? Well, CT scans are effectively 3D X-rays. The patient goes into a large circular scanner which will have X-ray emitters, and opposite those there'll be X-ray receivers. So the emitter will produce an X-ray which will go through the body and be detected by the receiver. If the X-ray goes through the body and encounters lots of high density tissue, the signal detected by the receiver will be low, and this corresponds to white areas on the final image. Conversely, if the X-ray goes through the body and encounters lots of low density tissues, then the signal detected by the receiver will be high, and this corresponds to black or darker areas on the final image.
So, as we can see here, we've got a table on the right hand side showing various Hounsfield units for different tissues. We're starting off at the top with air, which has a very low Hounsfield unit value of -1000. Then we come up to water, which is slightly more dense and actually has a Hounsfield unit of 0. Then CSF, which is slightly more dense just because it has things like proteins, electrolytes and other things in it, so it's more dense than water. Then we have white matter, which is between 20 and 30. Grey matter, which is more dense again at around 37 to 45. Then we have coagulated blood, so blood that is clotted, which will be even more dense than the brain parenchyma, which comes in at +50 to +75. And then by far the most dense tissue we can see is bone, which can be as dense as up to 3000 Hounsfield units. So how does this translate to the scan? So going from top to bottom of the table, we're going from black, essentially, which is air, all the way through to bright white, and everything in between is getting whiter and whiter as we go down the table. So on the screen now we can see an image which demonstrates the entire grayscale from pure black on the left to pure white on the right. And if we look at the scale as a whole, we can see that actually CSF, white and grey matter all have relatively similar densities. So if we were to use the entire grayscale for our scans, it'd be very difficult to differentiate CSF, white and grey matter because they'd all be very similar shades of grey on the scan. So to overcome this issue, we shrink down the grayscale, so we take all of these shades of grey from black to white and we map them over a smaller area of density so that we can use more shades of grey, white and black to differentiate between important structures like CSF, white and grey matter. And so there will be a bigger difference in grayscale for these relatively similar density structures. Something to note is that anything left of this sort of shrunken down area, so anything left of the box on the image, will be black, and anything to the right will be pure white. So we've now mentioned that we can shrink down the grayscale and map it over a certain area of density to get greater discrimination between different structures depending on what we're trying to look at. So we talked about in the example of CSF, white and grey matter, and if we map this small window of the grayscale over the CSF, white and grey matter density area, then we get very good discrimination between these structures. Now this gives rise to another concept called windowing, in which we can move this small box anywhere up and down the grayscale, and we do this for a number of reasons. So if we're looking at some very similarly white structures such as bone, we may want to move the window that we're looking at all the way up towards the white end of the scale so that we can differentiate any differences between areas of bone. So for example, if we think there might be a fracture in a certain part of the skull, we might move the window up towards the white end of the scale so that we can get good differentiation between the white bone on the outer table of the skull to search for any fractures. And this is where you may have heard of bone window as a setting on any sort of imaging software that you look at. And bone window is essentially just moving the little window of density that we're looking at towards the right hand side so that we can differentiate any defects in white structures such as bone. So we've looked at the underlying principles behind the CT head scan. Now we're going to move on to a systematic approach to interpreting the scan itself. As with any other radiological investigation, it's important to have a good structured approach so that we can go through every aspect of the scan and not miss any potential pathology along the way. So we're going to start off by confirming the details of the scan, so the patient name, date of birth, and when the scan was performed. We'll then comment on the imaging modality, which in this case will be a plain CT head scan, and the cut of the scan. So if we think about the anatomical planes of the body, this is either going to be an axial, a coronal, or a sagittal cut. We're then going to follow the blood can be very bad mnemonic to work through the scan systematically. And that stands for blood, cisterns, brain, ventricles, and bone. So let's start with the first B of the mnemonic, which is blood. There are many types of intracranial bleed that can occur. We're going to focus on 4 main types today, which are extradural hematomas, subdural hematomas, subarachnoid hemorrhage, and intracerebral hemorrhage. So if we break down these names, sort of part by part, you'll find that the name will tell you whereabouts in this intracranial space the bleed occurs. So extradural hematoma is outside the dura, so will be between the dura and the skull, for example. So let's start with the extradural hematoma. So as we briefly discussed, this is a collection of blood outside of the dura mater. So that will be blood collecting between the dura and the skull. If we actually think about what the dura is, it is the outermost layer of the meninges and contains a number of important structures. So it contains the dural venous sinuses, which are venous drainage for the brain, as well as the middle meningeal artery. Extradural hematomas often come with a history of trauma. This is because most extradural hematomas are caused by a rupturing of the middle meningeal artery within this dural layer. The middle meningeal artery is particularly susceptible to rupturing because of an overlying thin area of skull called the pterion. It is the thinnest part of the skull and is formed at the temple where lots of suture lines meet. So if a patient experiences any trauma to the temple, there is a risk that you can get a fracture of the pterion, this very thin area of skull, causing rupture of the middle meningeal artery and causing this hemorrhage into the extradural space. So this blood that collects in the extradural space is actually limited in how far it can travel laterally around the skull. This is because the dura inserts itself onto the skull at suture lines, which are areas where bones of the skull fuse together during development. And these dural insertions stop the blood getting past and therefore prevents the blood from crossing these suture lines of the skull. So if the blood can't go laterally, it will build up pressure and cause the dura to be pushed in medially, creating this convex edge that we can see on the bleed here as the pressure builds up. You can think of this sort of like a hammock where you have 2 areas of insertion and a bowed convex edge where the pressure is building up. It's often described as a lemon shape. So if we were to interpret the CT scan on the slide, we would confirm the patient information. We would state that this is a plain CT head scan in the axial plane, and then we would identify a right-sided hyperdensity with a convex internal edge consistent with an extradural hematoma. Something else to note on this scan is that we can also see the red arrow pointing towards some hemorrhage outside of the skull, which is essentially just hematoma of the soft tissues overlying the skull and is known as a subgaleal hematoma. So we're now going to look at our second type of hemorrhage, which is the subdural hematoma, and there are a few key differences between a subdural and an extradural hematoma that you need to know about. So as we discussed before, an extradural hematoma collects outside of the dural layer, whereas a subdural hematoma collects between the dura mater and the arachnoid mater, and this creates a key difference in the way it looks on a CT scan. So if you look at the image on the right hand side, you can see that actually the bleed has a concave internal edge, creating a crescenteric shape to the bleed. And the reason for this is that subdural hematomas can cross suture lines. So they're not limited by suture lines and then bulge inwards. They tend to extend more laterally around the skull and maintain this crescenteric type shape. So on this scan, due to the higher pressure created by the bleed on the right hand side, we can see that some of the brain has been pushed from the right hand side to the left. Now we can tell that this is the case because there is a line that you can see on axial CT head scans called the falx cerebri, which normally runs directly down the middle of the brain. If you can see at the top and the bottom of this image, this falx cerebri has been pushed from the right side over to the left, indicating that there is a sign called midline shift, which essentially shows that the pressure on one side of the brain is causing the brain to be pushed over to the opposite side. So both of the scans below show subdural hematomas. They both have the generally crescenteric type shape that is characteristic of this type of bleed. On the left hand side we can see that the bleed is darker in colour, which is in keeping with a chronic subdural hematoma because the body has had time to break down the hematoma into a watery liquid. On the right hand side we can see a generally crescenteric bleed again, but actually the bleed is bright white, indicating that it is an acute subdural hematoma. But within this subdural hematoma, if you look very close, there are some areas of low density within the bleed. Now, instead of this being chronic blood, this is actually blood that is so fresh that it hasn't had time to coagulate yet. So the right-sided image shows an acute subdural hematoma with areas of hyperacute hemorrhage which have not yet clotted. So the third type of bleed we're going to talk about is the subarachnoid hemorrhage, which, as the name suggests, is bleeding below the arachnoid mater. So this is bleeding into the subarachnoid space, which is formed by the pia mater below, which is very well adhered to the brain, and the arachnoid mater above. And essentially the subarachnoid space contains CSF, some major blood vessels, and some dilated pockets called cisterns, which are just essentially pools of CSF within the subarachnoid space. So this creates a very characteristic bleeding pattern on CT scan. So if we look at the image on the right hand side, we can see that the blood has infiltrated this subarachnoid space, it's filled the basal cisterns and creates this sort of star appearance on the image. So we can pair this radiological appearance of a star-shaped bleed due to blood filling the basal cisterns and subarachnoid spaces with the clinical history, which is most commonly a sudden onset severe headache, which is often described as a thunderclap headache. So this slide demonstrates an intracerebral hemorrhage, which again has a very different shape to some of the other bleeds that we've looked at. So from first appearances, we can see that it doesn't really fit the description of an extradural or a subdural hematoma. It doesn't stick to the periphery. It doesn't have this well-defined, concave or convex edge. But at the same time, it doesn't follow the subarachnoid spaces and doesn't have this characteristic star-shaped appearance that we would expect from a subarachnoid hemorrhage. So intracerebral hemorrhages tend to be of very variable shape and size depending on which vessel is ruptured and what territory of the brain is affected. And there are two main subtypes of intracerebral hemorrhage. This is the intraparenchymal hemorrhage, which is just bleeding into the brain parenchyma itself, or an intraventricular hemorrhage, which is bleeding within the ventricular system of the brain. So there are a few main causes of intracerebral hemorrhages, and this can be hypertension, so just high blood pressure causing rupture of a vessel to cause an intraventricular or intraparenchymal hemorrhage. Another cause is an arteriovenous malformation, or an AVM, which is essentially just an artery and a vein which are fused together, and this high pressure arterial flow can cause this to rupture and again cause the intracerebral hemorrhage. And another cause is simply head trauma, where you get mechanical damage to one of the vessels supplying the brain. So if we were to describe the CT scan on this slide, we would say that there is a irregularly shaped hyperdensity within the left cerebral hemisphere. If we look a little bit more closely, there's also a small amount of hypodensity around this lesion, and these findings would be in keeping with an acute intracerebral hemorrhage with some surrounding edema. This CT scan shows a slightly different pattern of bleeding compared to the one we saw earlier. There is still intraparenchymal hemorrhage, indicated by this area of high density within the brain tissue itself, but there is also high density within the lateral ventricles as well, which shows that coagulated blood has made its way into the ventricular system, indicating that there is an intraventricular hemorrhage as well as the intraparenchymal hemorrhage. So in this short slide, we're just going to be talking about the basal cisterns, or the subarachnoid cisterns, what they are and what sort of pathology we may be able to identify by looking at them. So essentially, the basal cisterns are one of the many CSF pockets within the brain. So they are small areas between the arachnoid and pia mater where CSF collects. And as we know, CSF is important for protecting the brain from trauma and exchanging some of the waste products that the brain produces. So in terms of pathology that we can look for within the CSF spaces, we can look for blood, which is well demonstrated by the image on the slide. It nicely outlines the anatomy of the basal cisterns there. And as we can see, we have 4 labelled cisterns, and the blood tracks into all 4, creating an almost sheriff star type appearance, which is quite characteristic of a subarachnoid hemorrhage. We can also look for effacement, which may be a sign that one of the cisterns is compressed. And overall, we can look for asymmetry. So if one part of the cistern system is compressed and one is dilated, we might be able to see where that mass effect might be taking place. So we're now going to look at some examples of something called sulcal effacement, which is essentially the normal pattern of sulci and gyri, so the ridges and folds of the brain, being lost because the brain is being pressed against the skull, and this is normally associated with raised intracranial pressure. So if we look at these 2 scans on the slide, we can see a very clear difference in the sulcal gyral pattern between the 2. On the left scan, the sulci are very well preserved, they invade towards the midline and are low density, whereas on the right hand side we can see that there is almost complete loss of these sulci, indicating that there is a degree of effacement occurring globally throughout the brain, and in this case this is due to hypoxia causing swelling of the brain. So when the brain itself is damaged, we get loss of what is called the grey-white differentiation. So on CT scans you should be able to see a subtle difference between grey and white matter, and if there is a loss of this, it can indicate a number of things. So it may indicate hypoxia, there may be a lot of grey-white differentiation around a tumour or an area of infarction, or even in rarer cases a cerebral abscess, which we'll go through a little bit later on. So the scan on the left hand side shows normal, healthy grey-white differentiation in the brain. This is some areas of darker tissue towards the centre, and then as we go out towards the skull, some areas of lighter grey tissue. Now this represents grey matter around the outside of the brain, being connected by white matter tracts through the middle. However, if we move on to the scan on the right hand side, there's little to no differentiation between any areas of the brain at all, so we don't have these nice lighter grey areas around the outside connected by the lower dark density tracts through the middle, and it's all sort of one shade of grey all the way through the brain, and this might again be caused by a hypoxic brain injury or edema within the brain. So now we're going to move on to look at some abnormal shifts in brain tissue rather than the tissue being damaged itself. We're going to look at different types of herniation of the brain. So this is essentially one area of the brain moving to another area where it shouldn't be. And this can occur in a number of different ways depending on mass effect forces and where these forces are acting within the skull. So if you remember, the skull is a fixed space which doesn't expand or contract, so any change in pressure has to be compensated by a shift in brain tissue or shift in CSF. And when we get a large amount of mass effect and the CSF cannot compensate anymore, we have to get shifts in brain tissue as a result of this increased pressure. So there are a number of different types of herniation in the brain, and they can be quite hard to appreciate in a 2D plane, so you might have to take a bit of time yourself getting your head around where these areas of brain are moving in a 3D space. But the image on the slide illustrates quite nicely a small summary of the types of herniation and which areas of the brain are affected. So if we quickly go through each type of herniation, we can see subfalcine herniation, which is indicated by this arrow in the centre towards the top of the image. And this is when the cingulate gyrus of one side of the brain is pushed against the falx cerebri, that ridge that runs all the way down the brain. If we take a little look further down the image towards the centre, we can see uncal herniation or transtentorial herniation, which involves the medial temporal lobe being pushed down due to a mass above it across the tentorium cerebelli. Now, the tentorium is essentially the distinction between the cerebellum and the brain tissue itself. Another type of herniation we can see on the image is tonsillar herniation, which is more commonly referred to as coning. And this is movement of the cerebellar tissue down through the foramen magnum. And this can be dangerous for a number of reasons, but mainly because the brainstem carries a lot of the respiratory centres for the brain. And so if you get significant compression of the cerebellum when it travels through the foramen magnum, this can cause an arrest in breathing. So our final type of herniation that we can see on this image is transcalvarial herniation, which, if you can see in the top left-hand side of the image, is herniation of the brain through the skull itself. So this might be as a result of an injury to the skull which causes a piece of bone to become dislodged, or after a neurosurgical procedure where a hole is created in the skull. So now we're going to discuss why you might get hypodense areas on a scan. This is obviously outside of the hypodense bleeding that we covered earlier. But some of the reasons are air, so pneumocephalus, which is air within the skull. And the reasons why air might get in is after a neurosurgical procedure or after a fracture, which allows air in. Edema is also hypodense, which can surround tumours in many cases, and also fat, because this is less dense than brain parenchyma itself. So we're going to briefly talk about some of the reasons you might get hyperdense foci on scans. So we spoke about areas of acute blood being hyperdense earlier, so that's the extradural, subdural, subarachnoid, intraventricular and intraparenchymal bleeds. But you can also get thrombuses. So if we look at the image here with the red arrow, we can see a small area of hyperdensity in quite a linear fashion, and this represents a thrombus within one of the vessels in the brain. Also, we can see that calcification can also cause areas of high density, and interestingly, the choroid plexus in the lateral ventricles is often calcified on scans, which can cause some confusion when interpreting these images. So we're going to quickly take a closer look at tumours as a cause of increased density within the brain. These vary widely depending on whether they are primary brain tumour, malignant or benign, and their pattern of spread can often be fairly different depending on the histology as well. But in general, there are a number of features to look out for when you identify a tumour. So we've already spoken about edema, so an area of decreased density around the tumour. But tumours are highly vascular for the most part and can cause hemorrhage. So there might be bleeds within or around the tumour. And some tumours calcify at quite a high rate, so you might see small areas of calcification in the tumour itself. And because the tumours take up space in the brain and within the skull, they can also cause mass effect, which might be in the form of ventricular effacement or even midline shift if they're large enough. So here we can see an example of a meningioma, which is a tumour of the meninges, as the name would suggest. We can see that it's not very well defined, it's very irregular, and there's also a large amount of hypodensity around it, which represents edema from the tumour. We can also see that there is complete effacement of the left lateral ventricle, indicating that there is a degree of mass effect. So all of the previous scans that we've looked at have all been plain CT head scans with no contrast. But sometimes if we want to better identify a lesion, we could administer contrast to see how it reacts. And there are a number of different responses. First of all, homogeneous enhancement is where the entire lesion will light up essentially with the contrast. But some lesions, only the edge enhances, creating a ring of enhancement after contrast is administered. And this is called a ring enhancing lesion. And depending on whether the lesion is homogeneously enhancing or ring enhancing can mean that the underlying pathology is different. Now we're going to move on from the brain tissue itself and focus on the ventricles, which are essentially pockets which hold volumes of CSF. So sometimes there can be some areas of increased density in these ventricular spaces. One of the reasons we discussed before was an intraventricular hemorrhage,
which is an extensive opacification within the CSF space of the ventricle. But occasionally the choroid plexus can become calcified and so cause an area of hyperdensity within the lateral ventricles. These are usually bilateral and symmetrical and tend to be much smaller than any intraventricular hemorrhage would otherwise be. When we've been looking at the previous scans, we can see that the ventricles are all roughly the same size, but the ventricles can increase in volume, which is called ventricular megaly, due to something called hydrocephalus, which is essentially the CSF spaces of the ventricles expanding for a multitude of reasons. And these reasons can be split into communicating and non-communicating forms of hydrocephalus. Communicating forms are due to an increase in the production of CSF, whereas non-communicating or obstructive are due to an obstruction of the flow of CSF, causing a blockage and therefore dilation of the proximal portion of the ventricular system. Depending on where the obstruction is, you'll get dilatation of different portions of the ventricular system. So for example, if you get a very proximal obstruction, you may only get dilatation of the lateral ventricle, whereas if you get a very distal obstruction, for example at the fourth ventricle, you'll also get dilatation of the third ventricle as well as these more proximal portions of the CSF drainage system. Another reason you may see hydrocephalus on a scan is due to a decrease in the amount of brain tissue in the skull due to either atrophy or other damage which has caused cell death. And in this case, the pressure in the ventricular system will overcome that of the surrounding brain within the skull, and you'll get ventricular dilatation. And this process is called normal pressure hydrocephalus. Ventricular effacement is a feature that we've seen on some of the previous scans in this talk. So essentially it's when there's an external pressure exerted upon a ventricle to push the walls together partially or completely to create a thin ventricle appearance or a completely absent ventricle on one side. Now, anything that can cause an increased pressure in an area of the brain may cause ventricular effacement. So for example, edema or hemorrhage or a tumour can cause the ventricle to become effaced. Ventricular effacement tends to precede midline shift as a marker of mass effect. So when we're talking about ventricular effacement, midline shift and other pressure related concepts, we have to remember the Monro-Kelly doctrine that underpins all of these. So essentially the Monro-Kelly doctrine states that because the skull is fixed and inflexible, it means that the intracranial compartment is a fixed volume compartment. This is made up of brain tissue, CSF and blood. So if we have an increase or a decrease in one of these components, there needs to be compensation from another component. Otherwise there'll be an increase or decrease in pressure. So when there's a bleed in the brain, there'll be an increase in the blood component of the intracranial compartment. And to prevent a rise in pressure, the body will have to shunt CSF away from the intracranial compartment to maintain the normal volume of the intracranial space. Now, the body can only compensate up to a certain point, and when no more CSF can be diverted, there will be an increase in pressure. Now, this increase in pressure will mean that the brain tissue will be pushed out through the foramen magnum, and this will cause coning. And if CSF increases, for example, because of obstructive or non-obstructive hydrocephalus, then blood will have to be shunted away from the brain. And the body does this by causing vasoconstriction of the blood vessels to shunt blood away from the intracranial compartment to prevent these pressure increases, which would ultimately cause the patient to cone. So the last B in our mnemonic is bone. And we're back to our concept of windowing now, because when we want to view bone, we tend to want to see very small changes so that we can pick up occult fractures within the skull. So we'll choose a windowing setting which is appropriate for us to see bone but not much else, and then we'll look for these small discontinuities of the bone that we can see indicated by the red arrow. Some associated features with fractures of the skull are also little air locules which you might see as pneumocephalus that we discussed earlier, which will be small areas of hypodensity within the inner table of the skull. So thank you guys for watching. I know that was a bit of a whistle-stop tour of CT scans. We covered quite a lot of concepts, so it might take you a bit of a while to fully digest all of them. But hopefully that's given you all a nice basis and a nice system for interpreting CT scans, and hopefully you're a bit more confident when you're asked to interpret them in the future. If you have any questions, feel free to get in touch, and please leave any feedback you have below. Thank you again for watching, and we'll see you in the next video.
If you enjoyed this video, check out the Geeky Medics collection of over 500 OSCE stations and put your OSCE skills to the test. You can practice with friends, create your own study group, or team up with another member of the Geeky Medics community with our OSCE Match feature. Sign up today to access our selection of free OSCE stations.